RFK Jr. doubles down on his promise for an answer to autism. Measles spreads to more states, and U.S. health policy turns to Europe for ideas. This is America Dissected. I'm your host, Dr. Abdul
And I'm your co-host, Dr. Caitlin Jetelina.
And we're recording this on Tuesday, April 22nd at 2 p.m. Eastern Time. Caitlin, first of all, before we jump in, how are you? How is sunny San Diego?
It's sunny and it is beautiful here. We're doing good. I think it's pretty beautiful across the nation right now, no?
It is. It's lovely. But as we discussed last week, our lovely spring also comes with like a nose full of pollen. So there's that. But I'll take it.
Ticks, right?
Yeah, probably ticks too. Probably ticks. There's that whole, we have to check our kids every time they go play outside in the grass because this is the first time they can play in the grass for like 6 months. But, yeah. Okay, keep rubbing it in. All right. On that note, let's start with one of the hottest stories in health this week. RFK ignited quite the firestorm. Here he was last week at his first official press briefing as HHS secretary.
Autism destroys families. More importantly, it destroys our greatest resource, which are our children. And these are kids who will never pay taxes. They'll never hold a job. They'll never play baseball. They'll never write a poem. They'll never go out on a date. Many of them will never use a toilet unassisted.
So first, autism is a really, really, really challenging condition for children and families across the country. That said, there's a reason we call it a spectrum, right? Because that's what he's just said is not necessarily true of all children who are on the spectrum. And that drew a certain amount of consternation from folks. Some with autism and their parents were outraged at what he said. Others have said they're glad that he's drawing attention to the issue. But a lot of them took to social media, as we do in this year of our Lord 2025, to set the record straight that most people with autism can lead healthy and fulfilling lives. And he tried to do some damage control on Hannity's show last week. He said he was only referring to people with autism who are nonverbal, which is, of course, is a small slice of people who are on the spectrum. I want to sort of step back here, Caitlin, and just as we think about this, right, there's a broader claim that he's made. And of course, that was the sort of center of his announcement, that autism is a preventable disease. And it goes to the heart of where some of the science has been less clear. Now, of course, when he's saying this, saying we're going to get the science there, then the question becomes, well, is it because all of the previous science was wrong, or is it because you're actually just not talking about science? Caitlin, can you explain some of the conflict at the heart of this challenge?
Yeah, I mean, the problem with labeling it as an epidemic is we actually don't know if autism is skyrocketing. We know, we've talked about this before on the show. Now, with a preventable disease, I mean, I have a really hard time believing that this is true, given that we know about 85% of autism is explained by genetics, and genetics are what we're born with. It's what we've had for the previous few decades. And it's one of the reasons why a lot of epidemiologists are questioning if there is an epidemic, given that largely due to genetics. Now, there is a really interesting question, though, is what's happening with the other 15% of that? Is it environmental stressors that we're seeing? Now, if those environmental triggers are preventable is a big question, because we know that, for example, advanced parenting age increases the rates for autism, premature births also, and those aren't necessarily preventable things. They're outcomes of our larger society. And so, I mean, we'll see. I think the challenge that Kennedy is seeing, rightfully so, is that this isn't necessarily what the autism community wants answered. And we need participatory-led research from stakeholders that are most impacted. And what we continue to hear over and over again, especially, last week when that uproar came after his comments, is that time and money could really be spent better helping people live healthier lives while celebrating autistic strengths. And a lot of these words and talking points and framing is just not doing that.
Yeah, I agree with you entirely. And I think one of the dangerous aspects of this is that when you talk about people with autism, like you said, that there are real strengths that can come with this. But it's also the kind of situation where you've got families across the country, frankly, across the world, who are working to provide the best possible life for their children and for themselves. And when you lay this out in a way that doesn't acknowledge that and doesn't embrace that and doesn't focus on how to empower folks with autism, you kind of miss the boat.
So the other thing that has rose to the surface, especially yesterday, was the announcement from Jay Bhattacharya of how they're going to answer this question: what is causing autism, and particularly around environmental concerns. And the answer was that they are going to create a massive database by triangulating all sorts of different data sources, all the way from medical records to Google Watches to you name it. And then they're going to give research grants to researchers through the regular process at NIH. What they also announced is that they're going to start an autism registry. And that made a lot of people nervous. I think rightfully so, because when you hear registry, you think, a list of names. It's not clear if it's going to be de-identified. Us in public health do use registries for other health topics that are de-identified, like SEER, right? Cancer outcomes. So how they do this, how they protect the privacy, how these researchers figure out how to leverage this database is going to be fascinating to watch. I have no confidence whatsoever they're going to find answers by September to do all of this. But we'll see how this plays out.
Yeah. Katelyn, I mean, nothing in what RFK Jr. shared inspires confidence that this government is focused on empowering people with autism. That's not to say that they're not. I'm just saying that if your comments start out with painting everybody with autism as the most severe cases and focusing entirely on what they can't do rather than what they can do, it's hard for me to imagine that will inspire confidence in giving your name into this registry if you're someone with autism or a family with autism. And then the second part of this is that they've just cut a whole bunch of their workforce, and they've cut people who manage data. So the security of the data that you give the government is in question. The other part of this is that you and I have both done epidemiologic research, and in theory, it should be really easy to combine different sources of data and help them intercalate together so that you can get better answers. It's really hard to do, right? Because the data often is, it's not, you're not getting the same data on all the people. And so the question is, if you have Google Watch data from some people, how do those people differ from the people who don't have it? And if you're now trying to lean on that data and you're actually just identifying correlations with the variables that predict you having a Google Watch, then you're not actually saying anything at all. And that makes it really tough, which I'm not saying you can't do. I think this is a perfectly fine approach. The hard part is doing it by September, right? So
there's no way. There's just no way it's by September. And you're right. I'll be honest, I was actually really excited to hear about this effort to triangulate different data sources. I just think that we in public health do not think creative enough with data. And I wonder what AI can do here, honestly, is I'm not an AI expert guru, if it's up to par with something like this, like matching matching medical records or names or places or spaces. But that may be a place where we do find headway and answer really hard questions. There's no way by September. I mean, it's going to take an IRB until 6 months. I don't get that timeline.
Especially when the IRB, just half the IRB people lost their job. Anyway, look, I think all of us would love this to be a success, but we want it to be a success in a way that people who are living with autism and families that have been touched by autism want it to be helpful and effective. And I want to give the last quote here to the autism community, specifically the Autistic Self-Advocacy Network. And their quote was, quote, "To speak as though our existence is some kind of calamity that must be eliminated is a form of eugenics, the dangerous ideology based on the idea that some people are born to be burden on the rest." And I think it's important to take that seriously because, there is a history, and I'm not saying at all that RFK Jr. or any of the folks around him are trying to do this, but there is a history when you frame a condition only around the worst aspects of it, and you don't center people and their own voices who live with that condition, there is a history in our country and in the world of sometimes doing things that ultimately end up hurting. And so I just think it's important to make sure that we're centering and engaging the voices of folks themselves in their own self-determination. And the thing about science, especially now, is with the technology that we have, right? There's no world in which this work should be done without folks in the community right at the fore. And it feels as though just in the language and in the approach that I would have liked to see more voices of folks living with autism involved. I want to move here to the other actual epidemic that we're dealing with, which is measles. Katelyn, can you give us an update on where things stand?
Okay, measles. I feel like I'm just a broken record every week, but it is spreading a lot. I mean, we are at more than 800 cases in 25 states. Half of the states in the country, 10 states have active outbreaks right now, which means 3 or more cases that are connected. And our local public health departments are just strained right now to try to keep this measles, all of these measles sparks under control. Interestingly, Louisiana, Missouri, Virginia all reported their first measles cases. These are usually sporadic cases from international travel. Whether these one-off cases turns into wildfire just depends on the local, hyper-local vaccination rate. So far, 85 people have been hospitalized. 3% of these cases were among people who are vaccinated. And like we say every week, but we need to say it again, there's likely a very severe undercount of cases right now. So we'll continue to follow this, but I would venture to say in about maybe a month or two, we are going to be the highest measles case count in the past 25 years in the United States.
Meanwhile, we are not hearing as much about this from HHS, right? Because so much of what you look to in leadership is directing our attention to what we ought to prioritize. And a lot of the way you do that is what you spend your time talking about and focusing on. And so we're having major announcements right now about things that are not white hot outbreaks in our country, which suggests to us that they just are downplaying this very serious and deadly disease. And to your point, Katelyn, like worst in 25 years. And the best single thing that folks can do to protect themselves is to get a safe and effective vaccine, but you're not hearing enough of that. And remember, either last show or 2 shows ago, we were like all applauding because he said it was safe and effective. But the key point, what you really want is not that the HHS secretary says it's safe and effective, but that they're everywhere all the time reminding people that it's safe and effective, and that this is the single best thing they can do to protect themselves and their loved ones. And you're just not getting enough of that.
I will say, Abdul, a lot of people are actually wondering why all the panic behind these measles cases, right? Is public health overreacting? And I kind of see their viewpoint, right? Measles hasn't claimed nearly as many lives this year as the flu or the opioid crisis. And compare our numbers in the United States to, for example, Europe last year that saw more than 127,000 cases of measles. But the answer is this alarm isn't just about the risk of measles. It's also what measles represents, that it is more than just a disease flare-up. It's a symbol, right? Broken trust, eroded progress, rise of individualism, replacing collective good, a system cracking under the weight of disinvestment and distrust. And so I guess I'm not surprised that RFK doesn't want to bring that to the spotlight. And he is trying to redirect attention away from measles because that puts a bad light on him. He created an entire career over the past 20 years sowing doubt in vaccines. And it's really disappointing to see.
On that note, you wrote this week on your Substack, your local epidemiologist, which everybody should go to and hit subscribe if you're not already subscribed, about some vaccine policy, right? First things first, ACIP, which is the Advisory Committee on Immunization Practices, they had their meeting that had been postponed 2 months ago. Can you tell us a little bit about what took place and what it tells us about vaccine policy in our country?
Yeah, I mean, I was watching this like a hawk, right? Because just to remind everyone, ACIP was delayed by Secretary Kennedy for about 2 months. And this is one of the levers he can use to influence vaccine policy in the United States. And interestingly, it was pretty boring. It was mostly business
We
as
love that.
usual. I do love
That's good.
it. And it shouldn't be news, but it is these days that, one of our important levers are holding up. The committee makeup hasn't changed since the Biden administration, and these are the people that vote on policy changes. The content was solid, right? Very thoughtful discussion, clear justification for policies, no conspiracy laced slides. And so yeah, it was refreshing to see. There's certainly still time to change the entire makeup, but that's where we are today. With that said, there are three things that were not business as usual. One is a streaming scramble, right? The administration cut most CDC communication staff, so they couldn't really live stream this event nicely. There was definitely glitches.
The
Two,
CDC is just like the rest of us, Caitlin, right? I mean, who among us has not tried to live stream something and had glitches?
I know, especially without your comms team. Like, can you imagine a bunch of epidemiologists figuring out how to live stream ACIP meeting?
You see me? This is me. Hey, are you hearing me?
You're on mute. Yeah, so there's that. I mean, there's a new voice at the table for sure. Her name is Dr. Tracy Hogue. FDA sent her as a liaison and replaced the previous FDA employee who usually comes. This is basically a political appointee, and she's a sports medicine doctor known for very vocal criticism of COVID policies, as well as has a very long track record of misrepresenting science. Her voice was definitely known at this meeting. She was questioning the safety and effectiveness of multiple vaccines, not just COVID, including Mpox. Zooming out, there's another big change in US policy that I'm seeing. And I truly don't think this is due to political interference, but it is this US is the culture, the people, the way people are thinking about things are shifting their overall approach to health policy to look more like the European model.
Look, I think you're right. Like, this has been a trend that has been moving, and there's some real substantive parts to this that are important to watch. Some of the moves on food dyes and food additives and even fluoride in water. But also it's so counter to a lot of what we hear about how this administration and generally how we think of ourselves, right? The whole idea of America First picks up on this notion that Americans are leaders, that we lead and not necessarily follow. But a lot of the argumentation that you hear in the Maha verse is, well, in Europe, they do X, Y, and Z. Yes, in Europe, they do X, Y, and Z. And look, I actually don't mind us following some of the more stringent practices in Europe. But if we're going to do that, I really would love to guarantee healthcare for everybody, like they do in almost every European country. And I would also really love us to be in a situation where we are actively thinking through the model that we can apply beyond simply what Europe has done. Right. I will say that there may be a saving grace in this, in that in Europe they follow science, and so it may be that this approach at least allows us to benchmark to European interpretations of the science, so that it can potentially hold back some of the worst excesses of what an RFK-driven HHS might be. Caitlin, what's your take?
Yeah, I mean, my take is that we have to be very careful comparing and making US policy based on Europe, exactly because what you said, there's drastic country to country differences around the health landscape, right? And so that's really why I think it's really important to have a big discussion on whether we get rid of universal vaccinations for flu, for example, because if we don't, we cast a smaller net, and more people will be lost in that net than what we see with other countries.
Caitlin, one example is on flu or COVID vaccine recommendations, right? Here we recommend COVID vaccines, for example, at everywhere greater than 6 months for everyone. Whereas in the UK, they have a very different approach. Everyone over 65, folks in care homes, people who are high risk who are older than 6 months, someone who's older than 12 who is a household contact of a person who's immune compromised. So they're a lot more specific about their recommendations. But to your point, like there's just a different context, right? In your mind, what do you think are the risks of being more tailored around this approach, given the U.S. context?
I mean, it's fair to wonder why all of us high income countries have all the same vaccines, look at the same data, but come to different conclusions around policy across countries. And the one reason is landscape, right? Our health landscape is just entirely different from country to country, particularly those in Europe, right? The US health system is subpar. Health insurance is mostly voluntary. The healthcare capacity is lower than average of other high income countries. Our safety net is just unacceptable. We have like zero paid leave. We have less spending on unemployment, a lot more poverty. Health status is poor. So all of that to say is that fine, if we want to move towards a risk-based approach, I think that conversation is certainly necessary, but we cannot lose sight that the US just has much less wiggle room to mess up than other countries because of all of these poor suboptimal systems we have here. And so we usually have to cast a larger net. And we've learned that from like the flu vaccine, for example. So it'll be really interesting to see what happens in June at ACIP. That's when this committee really has to make a decision whether we go towards universal vaccinations for COVID versus risk-based. And I don't know how it's going to land. I think this is one of the first times that I think there's going to be a really robust conversation within ACIP and then within our greater culture in the United States too.
And look, I'm not actively opposed. I just wanted this to be evidence-based about the outcomes that we're trying to optimize to. And so long as we do that, I feel okay. The problem is sometimes when you mix and match, you end up trying to nip and tuck here or there, and you end up without the kind of coverage that Americans need and deserve. So let's see how it goes. America Dissected is brought to you by the Beaumont Foundation. Every day, public health professionals across the country work to promote well-being in their communities, but most people don't understand what they do and why it matters. By building public health literacy in communities, we can improve trust and contribute to better health outcomes. Find new research-tested messaging to communicate about public health, plus useful tips for the real-world situations you face at thebeaumont.org.
While we're on the subject of COVID, Abdul, did you see what pops up on the screen when you type Covid.gov into your browser?
It's the same thing that pops up in my dreams when I think about all the things that make me anxious. It's basically Donald Trump walking out of a gigantic that says lab leak. And I'm like, was he the one who leaked it from the lab? Like,
I think
or
so.
did he figure it? I mean, is he the thing that's leaking from the lab? I don't know what the graphic designer at the White House was thinking when they made this, but I think they probably should think twice about it. Really one of the unsaid parts of this moment in American history is the degree to which like the White House has emerged as possibly America's greatest troll. And I mean, it was like a twist that nobody saw coming, but I mean, I guess it kind of makes sense. But it is a wild thing. And it's the White House taking a position on the origins of COVID-19 in a way that doesn't actually solve anything. And there is a broader point that I think we all need to reflect on here. You have an administration that is attempting to undo independent sources of truth. Now, COVID came from somewhere. It may have evolved in wild animals. It may have leaked from a lab. The current evidence doesn't demonstrate one way or another. But the idea that the White House would proclaim its position on this based on no evidence at all is an attempt by the White House to become its own independent source of truth, which for anybody who studies science will see as absolutely absurd. It's like, let's say you and a family member both went to medical school, you are debating a case, and your one cousin who, studied English is like, actually, this is what it is. You're like, all right, bro, thanks. But also, really? It's actually just embarrassing. But then the other part of that is also, there is something really dark in this, because this is the White House we're talking about, right? This is supposed to
Yeah.
be like a source that you can actually trust. And when you're leveraging the White House social media to make a claim that is supposed to be in the space of science to make, it tells us a lot about how they're trying to both pivot vis-a-vis other independent sources of truth, and also what it says about what they think the president should be able to to say and do.
And there was also just no action about this site, right? It was just completely political theater. Like I could see maybe adding concrete calls to action for safety improvements, for example, or some sort of policy based push for something around lab leaks and research and the need to be ensure a safer future, but that's not what happened here.
No, and look, I'm all for like I mean, lab leaks are real, and the fact that they still happen in 2025 is a real problem. And if in fact COVID did originate in a lab, this is a 5 alarm fire, and like we should really be doing something about it. The reality of it is that this has been studied ad nauseum, and in the absence of any new evidence, I think there's just going to be a split perspective on this. And then the bigger question is like, how relevant is it right now beyond trying to secure labs? Like the things that we would do because lab leaks can happen are the things we should be doing in labs anyway. How important is it to you that we get to the bottom of this, Katelyn? Like how much energy and effort do you think we should be continuing to expend on it?
I mean, I think it's an important question, right? COVID, there's no doubt, created a really dark time across the globe. More than 1.5 million Americans died, and we should be angry about that. But we're never, I'll say that we're never going to get this answer. We lost the window of opportunity to collect data, and disproving the lab leak or proving natural spillover is going to be close to impossible at this point. And so I guess I take more of the 30,000 foot view, is that we continue to just overlook the larger issue here. And this is what you're getting at, Abdul, that underlying all of this is the possibility of a lab leak, and the possibility of a natural spillover, and the possibility of intentional lab leaks. And we need to address all of these to ensure a safer future. And that's just not where this conversation has just become stalled. It's not creating anything new policies, new pushes for a better, safer future. So I'm over it.
Yeah. And laboratories should be safe places where things don't leak, period. So let's get about to fixing that. The reason that I think the White House is pushing this is because it feeds the possibility of a conspiracy that then allows them to second guess a lot of the decision making that was done during the COVID-19 pandemic, and then creates a subtext on which they can try to erase independent sources of truth, like scientific agencies. And that's why they're doing this, right? And I think it's just important for us to call out the game here.
Yeah, I mean, I was just going to say you're right. I think that this is a chess move by the Trump administration, not only to piss off scientists, which he did a great job at doing that. A lot of scientists took the bait here, but also as justification to disband scientific institutions, NIH, academic institutions, people who were genuinely curious about this answer. And that is their play here. And I don't appreciate that whatsoever.
Before we go, there are two other really important stories here. The first is Dr. Kevin Hall, who is the NIH's top expert on ultra-processed food. We actually talked a lot about his research a couple episodes ago with Dr. Dhruv Kullar. He left the agency. Katelyn, what do we know about this?
Yeah, so in 2019, Dr. Hall authored arguably one of the most important studies, right? A randomized controls trial, which is the gold standard, showing that ultra-processed foods leads to weight gain. As a scientist, he then did the next natural thing. Why, right? Why is this causing weight gain? Is it because it's addictive? Is it because hyperpalpability? Is it because calorie density? And he did a follow-up study, and he found that ultra-processed foods may not be inherently addictive, indicated by the brain's dopamine response. But as you could probably see where this is going, this directly contradicts RFK Jr.'s narrative that ultra-processed foods are addictive. Hall was interestingly, initially restricted from publicly sharing these results, which is pretty fucking wild. But then once he was allowed to comment, the NIH press office edited his response, really downplaying the significance. And then he announced his early retirement, citing censorship. He has been at NIH for 21 years. So across multiple administrations. And I think the biggest concern here is that when scientists are muzzled, it hurts public health and it doesn't allow us to move towards a healthier world or even a better food system. And it follows a really concerning pattern we're starting to see with recent departures. Peter Marks said the same thing and he was at FDA around vaccines. Kevin Griffiths said the same exact thing at CDC. He was in charge of communications. And so this pattern of muzzling scientists is probably one of my biggest concerns right now.
Yeah. The thing about it is we use science because it points us the way forward to make smart investments and save people's lives. Like that's the reason you allow science to just do what science does. And when the science doesn't agree with your preconceived notions, you change your notions. You don't change what is said about the science. That should be like obvious. But everything we've been saying about our fears about RFK Jr. and what he means, remember, this is a guy with a large following and a lot of popularity right now who has the capacity to go. He'll keep doing his science. I'm not worried about him getting funding, but I am worried that folks who are far less powerful and who are getting muzzled at the agency might not have the same opportunities. And so we're just not going to be hearing about situations where a RFK-led HHS is muzzling or reshaping their narrative in ways that will basically take these agencies out of the hands of the public as being fully about what is best for all of us and put them in the hands of RFK Jr. And this is a really, really dangerous and troubling situation.
Can we just for a second sit in the hypocrisy of all of this, particularly because Jay Bhattacharya is the NIH director now, and he said, quote, "I personally was subjected to censorship by the actions of the Biden administration during the pandemic. Science to succeed needs free speech. It needs an environment where there is tolerance for dissent." Like, what?
Yeah, we're trying to make it make
breath.
sense.
Here we go. Yeah, I know that was
It's
always
free.
a problem.
It's free speech when they're speaking, and the rest of us can just shut up. So.
Yeah. Last thing, it's going to be more bad news.
More bad news? No.
But we need to brace ourselves for more cuts at HHS. The Washington Post and New York Times obtained a secret memo from the White House last week, and it was basically Donald Trump's HHS budget proposal. And what the administration wants to see is about 1/3 of HHS budget cut, which is about $40 billion. That's a B, $billion. CDC's budget would be cut in almost half. NIH budget would go from $48 billion to $27 billion. Routine inspections to food facilities are going to be entirely put on states. They are going to add, or they want to add $500 million of research to fund the MAHA initiative, which is now called AHA, which is RFK Jr. would control that fund.
So basically, they're gonna gut the NIH.
Yeah.
And then they're going to put $500 million directly under the discretion of a non-scientist to guide science. Like that's what this budget lays out. And meanwhile, anything that you actually discover out of that science, all of the agencies that would be using that to actually turn it into public policy are also getting gutted. I mean, this is a wild thing. And I want folks to understand what they're trying to do with this budget is they're trying to formalize all of the DOGE cuts in ways that now sit in federal law. And you know, the danger of this is that we all get worse public services. We're watching as independence in a lot of these agencies, as we just talked about, is getting cut and is being directed directly behind RFK's pet projects. And it's really, really difficult to come back from these things. The other important note here, just for folks who are watching, they are not articulating any cuts in Medicaid or Medicare. So at least that's a good thing. But this is a really dangerous thing. And I think for all of us who just, paid a tax check, we're asking, where do our tax dollars go? And increasingly, right, they're not going to the things that are benefiting our society. I mean, HHS is one of those things that, I think most people agree on. And it's getting wiped out here.
Yeah, they're basically zeroing out HHS to see what breaks. And that is just not a very strategic or smart move when it has to deal with the health and the health of our societies. But really, the work is about to get started with Congress. Congress will be debating what should be getting cut, making plans, and that final plan, if voted on, will come out October 1st. And so the message I think we all need to really focus on about for those of us on the ground is we need to start contacting our representatives on a local, on a state, and a national level to talk to them about what's important to us for this health budget, and what we don't want to see change or what we do want to see change from it. And I hope that people find agency in that and realize that that's a very effective mode to instill change, at least the change we want to see.
Yeah. And to that point, Katelyn, your voice absolutely matters here because,
Yeah.
this is just part of a huge budget. And obviously on this pod, we think a lot about, the operating agencies within HHS. But when you're thinking about this within a broader budget that could, try and end the Department of Education or massively cut, Social Security or Medicaid, this becomes something that is less likely to get the attention it deserves. So you calling Congress and your representatives and senators and reminding them you care a lot about this really does matter. Okay.
We both take a deep breath. Let's talk about the interview this week. Who did you talk to?
Yeah, I talked to Dr. Gillian SteelFisher. She directs global polling at the Harvard Opinion Research Program. And they've done some really interesting polling of everyday folks, both Republicans and Democrats, about how they felt about the non-pharmaceutical interventions. So those things that weren't vaccines, that people in public health were advocating at the beginning of the COVID-19 pandemic. And I don't want to give away all of it here, but her research definitely surprised me about both the public's understanding of how important some of these tools can be and about the kinds of things that they would expect from their public health leaders if and when they want to use them. So, we've been talking for a while here that COVID-19 is not going to be the last pandemic, and we need to be ready for the next one. And so this was really helpful to understand where the public is as we prepare for the next one, be that in a year or in 50 years. So I hope that folks will stick around. And meanwhile, Katelyn, I know that you're about to go surf because California is California. We'll be taking nosefuls of pollen and sneezing.
And finding ticks. Yeah, have a good rest of the week. Have fun with that.
Yeah, thanks, Katelyn. I will appreciate you. All right, friends. See you soon.
Every episode of Trade-Offs is grounded in rigorous research.
I don't think that the findings of this paper indicate that there are major clinical risks to patients.
Thoughtful conversations.
I also was thinking that a lot of the anger, while real, is somewhat misplaced.
And insights into what the latest in health policy means for you.
And every member of Congress should be asking questions on both sides of the aisle about, hey, we're spending hundreds of billions of dollars. What are we getting for it?
We tell stories that cut through the noise, uncovering the data and personal stories that help you understand the stakes and the potential solutions to healthcare's toughest choices. Subscribe to Trade-Offs wherever you get your podcasts.
All right, let's get started. Can you introduce yourself for the tape?
Yes, I'm Gillian SteelFisher, and I'm the director of the Harvard Opinion Research Program at the School of Public Health.
So I have to ask you, if you were the director of the Harvard Opinion Research Center, what is your opinion about current goings-on in the world of academia?
So here's the beauty of me, is that I study other people's opinions. Like, I was the kid in the front of the class who was like, I have a question. And they were like, you could do that professionally. And I was like, I'm game. So mostly what I do is ask other people what they think. I love to listen. I do surveys. I do qualitative interviews, talk to people and find out what they really think about public health issues.
All right. Well, let's jump in because you guys did a recent study on attitudes around COVID era pandemic policies, things like masking and lockdowns and school closures. And you asked folks if they still supported those policies. Now, I have to tell you, as a sitting public health official, my expected response was like, no, we hate it. We hate you. We hate everything about public health. But that actually wasn't what you found. Can you tell us what you did find?
Yeah. So I think I really first want to say I empathize with your perception, right? It's like, I think you're not the only public health leader and communicator and, staffer who would say like, hey, I'm pretty much expecting like full on, like, we hate this. And I think that it's really hard for folks to not pay attention to like what's happening on social media and just remember like the people on social media, the people in the news are not representative. So my whole goal is to tell you like what's really happening. So take that in mind as I'm about to tell you that people don't hate it. I know, shocking, surprising.
Okay, but do they love it? Do they
They
love
don't
it then?
I mean, they're not like, psych, bring it back. Right? Love those emails. Get me a Bejeweled one, right? Like they're not saying that for sure. There is a narrow path. I understand it's narrow, but there is a real path. And I think it's important for public health folks to understand that it's not just what you see in the news. It's not just what you would hear from elected officials. There's a narrative that's going around that is actually inaccurate to the way that people think. And I think the risk is that actually that narrative begins to change people's views. So we have to get this story out too.
And what was surprising to you about what you found in terms of people's tolerance? And in all seriousness, right? Yeah. Obviously, nobody loved COVID era policies because nobody loves to live in a pandemic because that's shitty no matter what happens. But people are much more nuanced about what they're willing to tolerate in the setting where they know that there is an impending challenge and that we're going to have to do something about it. So what did you find that was surprising to you about people's attitudes around these things?
So we asked about 4 different kinds of policies. And we tried to ask about things that we saw happen during COVID and might be used again if the right kind of transmission was happening, right? So things like school closures, masking, vaccination of health workers, and restaurant and dining closures. So things that have impacted our daily lives and that went on for a long time in COVID. And we tried to like ask people in a way that wasn't like, okay, if we tried to do this for 2 years, what do you think? But we also tried not to ask like, well, if we once asked you to think about a mask, what do you think? Like we tried to get like, okay, let's kind of get middle of the road. Like you're going to have to do this for a few weeks. Like restaurants might be closed for a few weeks if, or outdoor seating or indoor seating at least, if there were high transmission. Schools might be closed a couple of weeks. We might have to mask in certain business settings for a couple of months, asking health workers to get vaccinated, not necessarily the general public, but, just that. And so they have some teeth that's sort of in there. And I think we were still expecting a lot of pushback. And we see is actually for the policies, you get a majority support for each of them. So it's right at the 50% mark on some, but it's also like, sort of it goes up to 2/3. And I was like, okay, there's more room than at least the media is telling me that there is. And I think that is an important message because it's not one we hear, right? That is not the major story that you would expect. And so I think that's something for public health folks to realize is there's an open conversation. Or an opening to a conversation, I would say, about these policies if we need them in the future. It's not a done deal.
I really appreciate that because the media would, if you consume the media about this, given that we just marked the 5th year anniversary of the beginning of the pandemic, almost every outlet has a think piece or two about how angry people still are and how much we lost because of public health policy, not just because there was a major pandemic that we failed to contain. What do you think is behind that narrative? I have my opinions. I'd love to hear yours.
Yeah. So I think there's a few things that happen. Okay, so there's media and there's media, first of all. Okay, so first of all, there's sort of major media outlets that are sort of traditional platforms. And I would say that part of what happens in those is that they are reflecting what's happening at the elected official level, right? And that's a story that elected officials have said. That's a story that they've told. And so there's some reflection of that in the media. And then, of course, there's social media that echoes that even more, and so forth. I also think there's something about tragically the way media stories are designed, and I don't see this as malice, right? This isn't like sort of poor intent. But what happens is, like, you want to make the story sexy, right? So here's what's not sexy. There's a lot of middle ground, and people are open, but it's nuanced. Like, wow, that is not a headline that anyone wants, right? So it's a nice frame. It's a sexier story if you have division. And that gets clicks. And so you start to tell a story that's more about the division. You're sort of riffing off what other media outlets are saying. And then when you go to do your story, like, you want to have, let's say, quotes from people who think things. Well, people who are in the middle don't have very interesting quotes. They don't say it well because they're like, I'm still thinking and I'm open, but I'm worried about this other thing. Like, it's just comes out kind of bleh, right? But the people on the extreme ends, they sound good. And so they make it into the story. And so it feels to people like everyone around them is like, oh, we hated this, or like, oh, and this is the stories, or is that it's totally partisanly divided, right? That it's 100% down party lines. And it's not. And again, I don't think it's out of malice. It's just like the nature of the way reporting is done. And we have to figure out how to make the middle ground sexier.
Yeah. It's I really appreciate the point that you are making here, which is that so much of what you hear out of media is about the attempt to find a narrative in something, and that narrative tends to sand off the less narrative-y parts of it, the complexities that exist. And then B, all those narratives get fed into an algorithm that tends to want to code into one extreme or another. And between those two things, you get a very unnuanced view that is not necessarily reflective of where the broader public actually is. I want to step back for a second, zoom back in on the data, because I think it might be helpful here for folks to understand. Yeah. Demographically, obviously, there are variations that are worth understanding. What did you find in terms of the demographic predictors of support for pandemic era policies, the ones that you talked about?
Yeah, so it's an interesting question. So as I said, there's majority support for each of the policies. Okay, so mask wearing is about 50%. It's because we sort of asked about masks for a couple of months, and then 2/3 for public closures, restaurant, bar, indoor seating, and then for healthcare worker vaccination. We also looked at the data and said, like, okay, so is there, would you be likely to support all of these policies, or one of them, or none of them? What does that really look like? And so you can sort of look at it that way, which is an easy way for us to talk about it, because basically, like, half of people are likely to support all of them. And only 19% are likely to support none of them. Not all likely to support, okay? So let me just talk about the differences there, right? So if you look at sort of those groupings, right, there are certainly partisan differences, right? So Republicans are less likely to support, Democrats are more likely to support. There are some racial and ethnic differences. So white people are less likely to support. People of color are more likely to support. There are some differences along sort of where you live. If you're in an urban area, you're more likely to support. If you're in a rural area, you're less likely to support. And those are things that we see kind of generally sort of like fits the narrative. So there's certainly, like, there are still differences between Republicans and Democrats in terms of their support. But what I want to think about, and from a public health and particularly a communication point of view, is that, like, where is the door closed? It's actually a very small percentage of the people. Mm-hmm. There's an open door for everyone. So even among Republicans, it's still a majority are likely to support at least one of these policies. So there's a conversation to be had. It's not that, and again, like, people aren't running like, oh, let's look forward to this. It'd be terrible, horrible. But again, the door is open, and this question of, like, okay, how can we have that conversation? How do we come to it with empathy? How do we come and say, okay, we know, like, parts of what happened last time were really hard. How do we do it better? How do we do that? And I think that's really where it needs to go.
What's interesting about this, and it's an important asterisk here is we're talking about short-term engagement with some of these. And the tough part, I think, with the experience of the pandemic is I remember sitting there late 2020 as an epidemiologist being like, damn, we're still doing this, right? Like, and I think a lot of folks felt that way. And then there were also folks who were, by virtue of the situation they were in, that our society put them in, right? They were watching as some people were able to protect themselves, and then they were deemed, essential, which was kind of another word for expendable in terms of how we were thinking about this. That created a very frustrating reality to the way that this message was being doled out, which was, it's going to be short term. No, it's actually going to be a little bit longer. Actually, it's going to be for a very long time, and some of these people are going to be left out. What do you see in terms of your data regarding how we should be thinking about how to talk about this prospectively, right? Because by definition, you're asking the question about a retrospective situation. And a lot of the tough part is when you're making public policy in the moment, you got to do it prospectively. You can't know when the thing is going to end or whether or not we're going to be able to do it effectively or what the inequities are going to end up being. So what do you recommend in terms of how we should be thinking about messaging this? Because you said there's a conversation to be had. Like, what's the nature of that conversation?
Yeah, no, you're hitting the hard questions, which is important. So it's true. We are asking about sort of shorter term policies. I think if you ask people like, hey, would you tolerate this for 2 years? They're going to be like, no. Right. And I think that's a pretty self-evident, and there's no, I don't need to spend money to do a poll to ask people about that. Right. We can know that. So these are things that are by nature challenging. I think, and I would say, one of the frustrating parts about COVID, right, was that I think there was this view before it happened that like it would be short term. Like I remember during pandemic preparedness that was like, it'll come in 12-week cycles. Do you remember having these conversations? Or like, it'll be 12 weeks and then it'll be on and off and we'll fly people from one part to another to support. Like, what are you talking about? Like, this is global. It hits at once. It's long. And part of the strategy, right, is to draw out the length so we don't have a huge number of people dying at once. Right. We're gonna, change the curve. And that is actually going to make it longer in some ways, right? But less devastating. We're going to not shut down all of our healthcare systems. That's the idea. But I think that, when we have the conversation, we also have to think about, as I often say, like public health is with the public. You have to have policies that the public is actually going to engage in. And so we have to think about not only like, well, how do we talk about it, but actually, how do we develop policies? Can we think about developing policies that can be shorter term? Can we think about approaches that can talk about, intervening at the moments of highest transmission and then actually pulling back, right? Like, can we actually have those conversations? Because I don't think there's a lot of tolerance for very, very long-term approaches. I mean, I hope we're not in that situation, obviously. And so what I'm also hoping is that we increase our surveillance, we increase our effectiveness around prevention of large-scale infectious disease outbreaks by putting some of these measures in place in the short term to prevent that, right? And so that would be the ideal, really. And, are there going to be problems? Sure, that'll be challenging. But the point is, like, we need to think of what that is. And I think, and there's going to need to be balancing with what people will tolerate and what the economic impacts are. In a way that I think that conversation there was sort of, I don't feel like there was much sort of like admission of like what was happening. Like it sort of rolled into the next thing. And I think that's really frustrating for people. And so I think if there are many lessons to be learned, but if we want to do it better, we have to acknowledge some of that up front and sort of say like, okay, this is what we're going to do for now. We're going to come back to you, but this is what we're going to do. And then really work on things like how can we actually have shorter term processes? And some of them are, and what can we learn from here? Where do we find the longer term was effective? But there are probably places where there are more effective short-term interventions that are targeted, right? And we can do that. Part of the data also, we asked people about their concerns. So we said like, okay, what do you think about these policies? And then, if I preach the message of, we come to people with empathy, right? And in public health, we are sometimes good at that, and sometimes we're not. Sometimes it becomes kind of preachy in another way, which is like, you should do this, and if you don't, you're a bad person.
Yep.
I don't like that.
I think you're absolutely right about this. And I think we're not honest about the notion that we're not somehow on the other side of a conversation. It's like we're all kind of doing this thing together, and it does suck not to know what's coming next and to be living under circumstances that are far from ideal, that have real other consequences to them. I think the point that you're also making is that this is a conversation we probably need to have now, so that should these tools need to be used, that you've had the discussion about, all right, here's where people really are on this. Here's why we would do it. And I think the tough part about that is there actually hasn't been a discussion with the public about like how much of this should we use, right? Like this is a public intervention, and this is something that we want to come to a situation, should it ever happen to us, God help us from it happening again, but should we have to use these things, all right, what would you like us to do, and how would you like us to think about doing it? How do you balance the cost and benefits of this particular tool being used? And I think that's what I really love about your work, is that you're encouraging this kind of conversation. The tough part, though, is that there are a lot of people who are actively, go back to our point about the media, actively trying to foreclose on public health interventions in the future. And they're actively doing it because of partisan political aims that, have us at this point, despite, the public's general support for these kinds of interventions, should they be needed for a short period of time, literally using the perceived media narrative that the public is totally against this to literally dismantle a lot of the institutions that would be in a position to protect us should we be in a situation have to face a pandemic again. And I want to get your sense on how you'd like us to leverage the data that you produce to drive that conversation, because I actually think that's probably the most important discussion right now, because looking back in the past, that's valuable, and getting a sense of what people think in abstract, that's valuable too, but only insofar as they educate what's happening in the future, right? And what we want to do is be in a scenario where we have this information, we've had a coherent conversation with the public, institutions are available to do the thing that the public wants to protect the public from illness, and that we can do that thing. And there's a group of people who apparently only represent 19% of everybody you polled, right, who are actively foreclosing on what everybody else wants. And how should we drive this conversation right now?
So it's an important question. And I think there are probably multiple things that we should be doing. And I'm going to say something that's maybe a little bit more controversial, in the sense that, so the data that I have here is a little bit to sort of hold. It's a reminder, okay? So whatever happens in the future won't look like this hypothetical scenario, right? There'll be enough differences, right? But we're trying to get at some of the principles, right? So we try to ask, what policies are you okay with roughly, where they're these are kind of things you could use. And we asked about what your concerns are, so that we know, and again, we can come to empathy, here are things people are worried about. And they are worried about longer term economic impact, they're worried about stigma too, that people will be stigmatized if they're not able to follow things. They're worried about things. They're also worried about greater social division. Nobody wants this. Let me just also say, no one wants this kind of divided country. This is very unpleasant for everyone involved. But I think having the conversation right now, broadly in the public, is kind of weird, right? Because the public is sick of COVID. Nobody wants to talk about it. It's a little bit taboo, and I understand. And I also feel like we need to understand, we're in public health. This is my major priority. I think about this all the time. Here's what none of my friends are thinking about, right? Okay, just have a little perspective on your job, what you care about, and also what everyone else is dealing with, right? So I think that kind of empathy has to be in the way that we present it as well. So I think there has to be a narrative that's happening that's sort of in the media sphere, right? We have to put it out there, okay, you can write a book and be everyone hated this, but I'm going to show you that actually that's not true, right? There is data to prove or show that that's not, nobody's written it all off, okay? Is that the conversation that I would encourage public health officials to be having right now, the town hall? No, I really wouldn't. I think we actually need to pay attention to what people care about right now in public health, which is not so much COVID and not so much pandemics, right? People are worried about a lot of other things. They're worried about mental health. They're worried about opioids. They're worried about, there's a lot of things that are affecting people. And we need to come to them. I think what happened in part in COVID, and this is not from the data, this is just Gillian's observations about the world, which is that, so nobody paid attention to public health before COVID. Like nobody knew what it was, right? We all said this, right? Like people would ask me like what I do. And even in public health, they're like, you focus on pandemics? They're like, what are those, right? Okay, now everybody knows. Now everybody's like an expert. But, this was like not, what people were thinking about. And so we have to kind of come back to the kind of public health we did before, where we were in communities and helping people with the issues they faced. And really like having people know you. And I think COVID scared people. I do a lot of work with public health agencies. And when I talk to them, it's really like, honestly, the most heartbreaking stories. Like if you know people in public health, right? Like literally the nicest people in the world who like are there because they want to help people. And however misguided you think that is, like whatever it is, like I hope that it's so clear like what people's intent is. They want to help people. That's why they went into the field. Nobody's in it for the money and glamour. Let's be clear. Okay. So, what happens is that the perception of public health now became this sort of like this sort of overlord of your life. And and like public health got kind of put into the light for decisions that were made at other levels, and sort of like public health, sort of blamed on public health agencies. Lots of the policies that went through actually aren't in the jurisdiction of public health agencies, but there are recommendations about things that like it all kind of linked back. And so people got blamed for saying that's really outside of their jurisdiction and outside of what they could do. And I think that people forget that there's like real people who actually care about their kids, who really want, people to stay safe. They really want to keep your grandma healthy. They want you to see her at the holidays. They want people to be able to come together, and that part of it is missing. And so I think that if my advice is like, keep this information in your pocket, because right now in public health, it's scary. You're worried about, people have like locks on the doors in the way they didn't have. They got, threats in a way they never had. Like it was a totally different world. And they were like a really unprepared group of people for it. Just honestly, this is like, came out, they didn't see it coming at all. And so, and people are afraid of the media, they don't want to talk. And it's like, you're gonna have to take a deep breath, like go out and do community public health. Be in the field with people, show your face, show who you are, because your intent is good and your willingness to have a conversation with people about what they experienced and be like, hey, I'm so sorry that went badly for you. I really like, whether or not you feel like you could have done things differently or not, like you can still say like, that sucked. I'm so sorry. Let's work together. I would really love to help you in this other area and in the future. Let's just be together and let me like hear what's happening for you. And that kind of connection, that we just need more and more of it. And I hear about a lot of local public health agencies in particular doing that in other spheres. And I think it's important. I think it's really actually the secret sauce right now. That's like the key.
I think there's a couple of big learnings to put an exclamation point on what you just shared. If the first time people are hearing from you, it's about mask policies and school shutdowns, you already failed out the gate, right? And then the second challenge is that a pandemic is a big, scary thing that most people, before, didn't have any context for, but all of them have their own health problems. And if you weren't a part of solving their health problems before the pandemic, and now you show up in this big, scary moment telling them that something bad is going to happen and asking them to do something that is a real sacrifice, they're not very likely to trust you, right? I think about what I share this often on this podcast, but people who can't afford their insulin know that they need insulin to survive. And if they can't get the insulin that they need day to day, and now all of a sudden you're coming with a medication that didn't exist a year ago to protect them from a disease they don't have yet, like the probability that they're going to trust you to do that is also quite low. And so if we're not about actively solving all of the challenges that people face in their lives, and even if it's beyond your ability to solve, doing what you can to try and solve it, then don't expect them to trust you when all of a sudden you come out of nowhere. And so we've just got to be about solving those problems, doing the work day to day to try and take on the challenges that people face. And if you do that, then people know who you are, they know what you're about, they know what you stand up for, and they've seen you before. And if you're coming to them and saying, hey, listen, there's this really bad situation that's about to happen, here's what we're going to try and do to protect our kids and ourselves, there's trust that's built there out of the work that you've done, right? And the problem is, I think in public health, we've let ourselves get marginalized out of solving big problems beyond the ones that are very, very clearly in our remit. And I just think that like we've got to be a lot more expansive and a lot louder about the challenges that we face, independent of what other powerful institutions in society tell us we can and can't work on, right? And I think like the other part of it is we also have to remember that public health, like the first word of public health is public. So if you're doing it privately, you're probably not doing it very well, right? And you said public health is with the public. I also think public health is just public, right? It's like it's public work. It requires you to be in communication and conversation with the folks that you serve. And if that happens for the first time under duress, don't expect it to go well, right? Because you don't have that relationship and you haven't practiced that back and forth that's required to do it well.
Yeah. No, I mean, I support everything you just said. I think, I always joke like my job is to put the public back in public health, right? That is the goal. I try to bring people's voices and then encourage people to make those connections. And we see, and it's not just now, right? This is a global and timeless truth, which is that we trust people for two reasons. We trust them because they have some technical knowledge. They are competent in a certain technical way. And second, because they care about us. And so we trust what they're going to say because we think that they have our best interests at heart. Mm-hmm. And if you are missing either of those things, we just trust less. We don't trust.
Yeah. And
institutions can sometimes show technical competence, but it's very hard to show compassion and connection. Mm. And so we're at a disadvantage, and we sometimes feel like, well, inside we all know. Like we all know that we're good people and we're trying really hard, right? And so we're like, oh, congratulations, we're doing such a good job. But you have to actually get out there, and there has to be like a face and a name and, the experience. And so much of what public health is about is like showing up at the community fair. Like there's a health fair, right? Showing up at the parent-teacher meeting and talking about what's happening. And it got really scary in COVID, and we also lost the ability to be in person together. And so we lost a huge advantage or strategy or tactic or whatever it is, like a way to be with people. And it's really a mistake. It's really, really devastating. And I do worry about the loss of infrastructure that will make that more difficult, right? So every public health person is like, yeah, I'd like to, but by the way, I'm like doing 5 jobs, right? So I just want to acknowledge that like there's a limit there, that people in public health are already working like a ton of hours and they're already doing these things as best they can. And I appreciate that. But I think there is, and I'm worried about like, as budgets tighten and, there are fewer people on staff and there's no budget for like, the pamphlets that are going to be at the fair. Like, I think we're going to have to get gritty and creative and be like, okay, well, we're just going to be out there anyway, right? Like public health is a passion. It's a belief. It is a way of wanting to treat the world with respect and support people in decisions that will make their lives better. And so, figuring out how to do that together, figuring out how to connect with each other, how to do it more efficiently, sharing resources, sharing that perspective is going to be the only way we're going to be able to move forward in the new environment. It's not going to be easy.
No, especially not now. Last question. There are a lot of listeners out there who don't do public health for a living, but support public health and are watching as public health agencies are getting clipped and cut. What is your message to them about what you've learned?
I think it's a similar message, actually. I think even if you're not in public health, there is this perception that like the world is divided and it's us and them. And well, the US is divided anyway into us and them. And I think my message is like, actually, there are people who maybe they voted different than you did. Maybe they have a different perspective on some issues, but you have common ground. Don't let the media tell you that you don't. And so go and talk to them, go break bread with them, go, talk. I think there's so many places in our lives, like, so I'll say a peeve that it's going to seem unrelated, but it's real, which is that like, if I go into a restaurant, like a quick restaurant, I ordered a kiosk and then like a person hands me a bag. Mm-hmm. But like, I don't talk to people. So I only talk to people who are just like me. Like what? Like there's all these like loss of like the sort of social sphere. So don't order at the kiosk. Go to the counter, talk to someone else, ask them how their day is, right? This is like, be in conversation, invite the relative that maybe has a different view to dinner, bring people. And I think, don't listen to the media narrative that it was all terrible in terms of people's, like everybody hated everything and that we're totally divided, because we're really genuinely not. And I know that's hard to hear when you're like, but the policies are so different. But just remember, like, what we think gets filtered through the electoral system, and then what elected officials do, and then what policies happen, and whatever, and it becomes like, it just moves like from the middle to like, right? I'm like right off the screen. We don't have to have it that way. We can like reground. And so I think, we're not all sharing the same news. We're not all sharing the same meals. Like, wherever you can, talk with someone who has a different opinion than you. Yeah. Because you're going to find out that actually they also really like their kids, or you have something in common. And I think that that perspective is really important, and sharing with them, like, what was your experience at this time, and what are the health issues you're thinking about? How are you trying to manage it? Where are you turning? Those are conversations that, the more we're siloed by news and by technology and by, structures of living, the more it's easy to get manipulated. And so I would say, hey, break through.
Yeah, I really appreciate that message. And, it's like, I think everybody hated the COVID moment. We just all hated it more similarly than we thought we did. Right. And I think that the narrative is COVID happened because public health. And that's not what happened. COVID happened because a virus evolved and affected a lot of people. And the response was painful, but the disease was the issue. Right. And so this was going to be a challenging moment. And we had a choice about, did we come together or did we break apart? And I think there are a lot of folks who want to use this moment to break us further apart. And I think we have an opportunity to come together. And I really appreciate you doing this work and reminding us that we're a lot more united in the way that we think about this than we thought we were. Our guest today was Dr. Gillian SteelFisher. She's the director of the Harvard Opinion Research Program and its global polling unit. Thank you so much for joining us today. We really appreciate you.
Thank you so much for having me.
That's it for today. You can find more content at our website, incisionmedia.co. Check out our shop at store.americadissected.com for our new America Dissected merch, including logo shirts, hoodies, and mugs. And don't miss out on our incredible Make America Scientific Again hats. If you have guest recommendations for the show, send us an email at info@incisionmedia.co. You can follow or subscribe to America Dissected on your favorite podcast platform and on YouTube at America Dissected. You can follow me on Instagram, TikTok, Twitter, and YouTube at Abdul no dash. And make sure to subscribe to Katelyn's newsletter, Your Local Epidemiologist, which breaks down the latest scientific evidence for over 300,000 readers. Search for Your Local Epidemiologist on Substack. Links to all of our sponsors are available in the show notes. I really do hope you'll check them out and show them some love. They make the show possible every single week. Finally, on your way out, don't forget to leave us a 5-star review. And if you're watching on YouTube, go ahead and drop us a like or comment. Word of mouth also still goes a really long way. So if you know someone who might like to keep up with everything that's happening in the world of health, please do let them know. America Dissected is a product of Incision Media. Our co-host is Dr. Katelyn Jetelina. Our producer is Andy Gardner-Bernstein. Video and audio editing by Nadine Malkonian. Our theme song is by Taka Sazawa and Alex Uguera. Sales and marketing by Joel Fowler and Nick Freeman at Big Little Media. Our executive producers are Tara Knight and me, Dr. Abdul Al-Sayed, your host. Thanks for listening. This show is for general information and entertainment purposes only. It's not intended to provide specific healthcare or medical advice and should not be construed as providing healthcare or medical advice. Please consult your own physician with any questions related to your own health.